welcome. I'm Bonnie Adario. This is my cohort, David Leduc. Danielle's missing tonight. She broke her foot.
Hold on one second. Your mics are not actually turned on. Let's do that real quick live. So hand me your packs. Okay, there's that one. And there we go.
Okay. Small detail. Okay.
All right. Got our timer, we got our mics on, we're official now.
Okay, one more time. Good evening to everybody live and in the room. I'm Bonnie Adario, founder of this foundation. This is David Leduc, our executive director. We're happy to have you all here tonight. Danielle is missing, who is usually our number one person. She broke her foot in Nashville. There's more to that story. I'm sure we can talk later, but I'm also sure she's dialed in. There's no doubt in my mind. Yes, she's in. So she would be very sad if I didn't mention that.
Hey, Gimpy.
Our special guest tonight is Sherri Millis with Foundation Medicine in Boston. Her title is Senior Medical Science Liaison and Research Scientist, and she's also a PhD. That's a big title, Sherri. We're expecting big things tonight. Oh. So let's get started. I believe you have a couple slides maybe that you want to show before you start speaking.
Yeah, I thought I would go ahead and give some background. We're going to talk about genomic sequencing and how that can impact your outcome as a patient. So I'm going to start with, just want to make sure those slides are up there. Try to level set everybody to what I'm going to talk about. And I'm going to start by talking about precision medicine or personalized medicine, two different ways that we talk about how we are improving patients' outcomes in cancer specifically by focusing on the biology of the patient's disease as opposed to looking at the histology. So for example, with lung cancer, we say a patient has lung cancer, but each patient is unique and each patient might have a different type of lung cancer. So we try to identify...
I'm sorry, Sherri, I don't think we can hear you either. I don't think Sherri...
She's fine.
I'm probably just not talking
down here. People are saying they can't hear.
Okay, you can hear me okay? All right.
Okay.
If you can't, just holler at me. I respond very well to being hollered at. So if we're looking at lung cancer, each one is unique, and so we're trying to identify at the biology what's driving our lung cancer. So historically, we would give every patient the same chemotherapy. It would make most everybody sick, and some people would do well, and some people would not do well. But in the era of personalized medicine, we're able to identify specifically what is driving the patient's cancer, regardless of the histology, in order to then treat the patient with unique targeted therapies, as we call them. And I'll talk a little bit more about that in a minute. But we're basically identifying what's the unique biology and then targeting that biology with specific treatments that are going to be more efficacious, or choosing not to use a treatment that's not going to have efficacy for that patient. So we're trying to help you get to the therapies that will help you respond and not give you therapies that are going to make you sick. So with that in mind, I'm going to just talk a little bit about our biology, and I'll try not to do too much of that. I'm a scientist, so I could talk about biology for days, but I know not everybody's very interested in that. In fact, my husband is an English major, and he tries to have me dial it down on most occasions. So, but with that, our unique biology is what makes us us. And I've got a picture of a piece of DNA there, and what happens is that the DNA is what's in every nucleated cell in our body, and it's what's telling our body what to do at the cellular level. For example, my DNA has specific genes. We all have genes, but they tell us different things. So it's kind of like words in a sentence, if you will. And in my DNA, I have a sentence that says, Sherri has brown hair. And over the course of our life, every time those cells divide, that DNA is replicated or copied, like on a copy machine, if you will. And when it's copied, if an error has occurred or damage has occurred, it's copied with that damage in it. So over the course of our life, what happens is that carcinogens, viruses, bacteria, all of this impact us. Or the sun, for example. Every time the sun hits our skin, it's has the potential to damage the DNA. So as that DNA is damaged over the course of our life, the body tries to replicate or copy the DNA, and it might copy it, that now damaged piece, in a way that tells it something different. So for example, my DNA used to say Sherri's hair is brown. Now it says Sherri's hair is gray. That's a somewhat innocuous DNA damage that occurs over the course of our life, but there's damage that can cause things like lung cancer. So the carcinogens in the environment that we breathe are going to impact us, et cetera. So cancer is typically thought of as a disease of the aging specifically for that reason, because the DNA over the course of our life has damage that occurs to it. We have systems in place biologically that try to correct that DNA damage, but that doesn't always work well either. So another area of DNA damage is in inability to repair that DNA. So based on that information, I want to now kind of change it a little bit and talk about how do we look at each individual's DNA to identify what damage has occurred or what change in the genes has occurred that is driving their cancer. So when I say driving, basically the DNA is, again, as I mentioned, causing the cellular functions to occur. And often the DNA damage that occurs in cancer is damage that does not allow the cell to stop or die naturally and have a new cell generated. And so it keeps being constitutively activated or activated forever. And so those cells keep dividing and keep propagating that misread DNA or that DNA damage. So how do we look at the DNA that's been damaged and identify what the specific damage is in order to then identify what kind of therapy will target that specifically damaged DNA and not the rest of the DNA? So with that, I have a quick schematic here that tells you a little bit about how we do this genomic profiling, as we call it. So genomic profiling is another way to say we're looking at the DNA to see what has damaged it, to see what the new coding sequence in the DNA is in order to determine the targeted therapy for a patient to use. So schematically, I've got a picture of a piece of tissue or blood, because we now can do this both by getting a tissue biopsy or looking at a portion of our blood, or a liquid biopsy as we typically term this. We put that into a magical science instrument that then looks at all of the DNA and identifies where those errors are in the DNA. And from that, we're able to identify the specific genes that are involved in the cancer. So once that information is generated, this gives us information about what is driving the patient's cancer. And we can then actually take that information and connect it to the therapies that are available on the market, or therapies that are in clinical trials, or even take that information to the pharmaceutical companies to help generate new drugs going forward. So with that, I'm going to just leave us on a blank screen so that we can talk about some of the questions that have arisen around genomics in cancer.
Okay, this is great. I thought, normally we go around the room when we first start, but I thought your introduction would get everybody excited to talk about what their specific issue is and what their target is. So you'll have an idea of,
yeah, that's great.
Of who we've got in the room. So Esty, your marker is a KRAS marker?
Microphone next to you there.
You have a microphone right next to you. Thank you, Francis. Okay. I caught Esty with a mouthful of pasta.
I don't remember. What was the first one?
I think it was KRAS. No, it wasn't KRAS.
It has 4 different letters.
EGFR?
PGA.
Okay.
I remember because nobody could test it, and then forced them to identify.
Okay.
At that time, 14 years ago.
Okay. And that was 14 years ago?
Yeah, about 2003.
Okay. So, yeah. And
so, what does that mean? Maybe she.
Yeah. Well, and you've recently had a little recurrence and had some radiation.
And that was something else that was on the other lung, and that was little spots that are ground glass type of things. and one of them didn't look too good. They don't know if it was bad or didn't look. Oh. Okay, one that
There
didn't look
you
good.
go.
So therefore, they did targeted radiation on it with the linear accelerator at Stanford. And he said, it looks fine, but I have to go first it was 6 months, now he says 9 months.
Okay, well, that's good news.
Yeah.
Okay, thank you, Esty. Francis?
I'd like to know the difference.
Yeah.
Yeah, hi, my name is Francis. A 10-year survivor. And that's actually the reason why I'm here. It's a good segue, actually, because what is it I want to do or need to do to find out if I should do one of these studies, find out if there is abnormal. I had lung cancer, so there was an abnormality in my DNA. So, can that be? Can we find out? What's the look into the future from that sense?
So you were never tested?
I was never tested.
Okay,
Yeah.
okay, and this was 10 years ago?
This is 10 years ago.
Okay.
And I'm sure there's many people like me, never tested. And rather than waiting for the shoe to drop, I'd rather be more proactive and find out, okay, is there anything I can do to not let the shoe drop?
And what therapy did you have, Francis?
I had a lobectomy, right upper lobectomy, and 12 weeks of chemotherapy. Yep.
Okay. Go ahead, yeah.
Hi, I'm Rosalind Spruitt. I'm Francis's wife and caregiver. So I'm very interested in any new developments in this field.
Thank you. Ron, are you going to say a few words? Ron Fong? That's you.
We're going to do the
You wanna go around?
We're going to do the inner ring first.
Okay.
Yeah, we'll go to the outer ring.
Okay.
Yeah. No, maybe not.
Nope, there he goes.
Hi, I'm Ron Fong. My wife Joan had an EGFR exon 19 deletion, a type 1, I understand. I just learned this week that there are 53 types of exon 19. That's amazing to me. Anyway, I'm an advocate at this point.
Hi, my name is Trey Regalo. I'm with Foundation Medicine, one of the companies that does this type of testing, and I'm here with Sherri and some others from our team.
Great.
Awesome, thank you.
I'm David Marshak, also with Foundation Medicine.
Krista Gallucci, also with Foundation Medicine. And Jackie Moriarty with Foundation Medicine. Thanks for having us.
Glad to
Lots
have you
of
here.
people for you to talk to later when we
That's right.
when we break. Thank you.
My name is Fred Palmer. I was diagnosed with non-small cell lung cancer in October of 2013. I'm currently on immunotherapy, and it's working.
Wonderful.
I'm very early on, even before Kaiser started testing for genomic profiling, I sent my tissue sample out to Foundation Medicine, and I was diagnosed, and they determined that I had a KRAS mutation, which was later confirmed now that Kaiser is testing for genomic mutations.
Okay.
Which is very good. So I'm very happy that I did that early on, because it's not that it guided the course of treatment so much, but it kind of confirmed various ways of going about treating the disease, and it just reinforced the kind of treatment that I had chosen.
Was that a recent switch to immunotherapy?
Yes.
Yeah, I thought so.
Yeah, I was on chemotherapy, now I'm on immunotherapy.
Yeah.
You had standard chemotherapy first.
Standard. Yes.
Yeah.
Right.
Okay.
Okay.
That's awesome.
Yeah.
That's awesome. And how long have you been on immunotherapy?
Since the spring.
Okay.
Yeah.
That's
May,
great.
May or so. And
And was any testing done to determine putting you on immune therapy?
yes. Yeah, they determined I had a 80% PD-L1 expression, which was very high.
Yeah.
So that.
Which is also a marker.
Yes, that's
Yeah.
right.
Okay.
Yeah. So I think that what needs to be done is I think that the HMOs like Kaiser just have to get with it and start doing more thorough testing. That's all there is to it. I didn't care about whether they cover the initial panel, that I requested or not. I just said, let's just do it. If I have to pay for it, I'll pay for it. I don't care. And I advise anybody to do that. If it's worth it. So that's been my experience.
Thank you, Fred.
Okay.
Thank you.
Hi, my name's Rick. I was diagnosed in February of 2015 with non-small cell adenocarcinoma. I've been treated at Kaiser as well. I went through 12 months of standard chemo, and towards the end, in October of 2015, I had one of my tumors wasn't responding, and so they did surgery, sent the sample off to Foundation Medicine, and what it did was it just reinforced the path, the direction my doctors were taking. I ended up not having any of the EGFR, ROS1 kind of mutations or expressions. So, but just a couple months after that, in February of 2016, I've been NED ever since. So no existence of disease. So, yeah.
So no markers showed up on your test.
Correct.
And you've been on what therapies? I'm curious because ND is awesome.
The first type of chemo I was on was carboplatin Alimta.
Okay.
Then Alimta only. And then after my surgery, I was on Taxotere.
Okay, okay. And when you progressed, did they do another test or?
No.
No.
They did the test after they had done the surgery, so that's where they got the best sample.
Okay.
I didn't have one done on my initial diagnosis.
Okay, okay, okay. Thank you.
I'm Rick, and I'm here with my wife for the last 6 years. And here she is, and she'll tell you her story.
Okay. Tina.
I'm Tina. I was diagnosed in 2010, November, so I'm coming up on 7 years here.
Yeah.
I did test positive for EGFR from the get-go, but they thought that I could also maybe have a better outcome with, at the time in 2010, with radiation and chemotherapy standard care treatment. And after I finished radiation and chemo, I went on Tarceva because I was positive for EGFR, and kind of, I guess, for insurance. And I've been on it ever since and have been having clear scans for the last 6 years, so that's really great. Just lately, though, I participated in a research study, and they sent my blood work to Foundation One, and no mutations showed up. Nothing. So I don't know, does that mean no cancer? Because there's no mutations, because don't you have to have a mutation to have cancer? I don't know. But anyway, then my second blood test that came from the research study at Stanford showed they did find a tiny little, the tiniest, smallest detectable cancer sloughed off dead cell in my DNA. So my question is, what is the significance of that?
That's a great question. Let's keep going around the room, but
okay.
That's a great question.
But come back.
Yeah, cataloging some really good ones here.
There should be a new driver
More
there
to come.
somewhere.
Hi, I'm Sally, and I was at very high risk, so I entered a study, the International Early Lung Cancer Assessment Program, and they found nodules in all my lobes, and I was watched, and after about 5 years, one of them grew to the point that they felt it was malignant, and I ended up having my lower right lobe removed, and there was no spreading. I mean, my lymph nodes and everything were fine. So I have been NED for the last 8.5 years. I'm being watched because of the nodules. And as you talked about having, knowing about the sample from before, when I was about 4.5 years out, I said to the oncologist, I can still get a hold of my tissue, because I checked at the hospital. It was a community hospital. And I said, so I'd like to have it tested. And he said, you're so far out that I don't think that would be worthwhile. If it comes back, or if anything grows, he said, then we'll test. Well, I cried a little bit because I wanted it done, but it hasn't been done. And knock on wood, I'm fine. And when I saw him in August after my last scan, he said to me, I have ground glass nodules just like Esty does. And he said to me, truthfully, I think at this point, if you get lung cancer again, it's not going to be from the nodules that are there now. I think the largest is 8 millimeters. And he said, I feel if you get it again, it will be a whole new primary entity. And which kind of makes sense because my mother had it 3 times. She lived 22 years with it. They never, in 75 when she was diagnosed, they never discussed staging with us. But they said it was found early and she didn't need treatment. And then 2.5 years later, she had a separate primary. And then she lived almost 20 years more with nothing. So if I can live like she did, I'll be thrilled. So that's my story.
Thank you.
I'm Ina, and I was diagnosed accidentally, just went in for something completely unrelated, and they found this was 2.5 years ago, they found a hard-boiled egg-sized, I'll just say that because it's easy to visualize, tumor in my left upper lobe, but nobody could ever get cancer cells. We agreed that it needed to come out, but when I went in for my surgery, there was never any positive cancer cells. And the reason there were no positive cancer cells was because the tumor actually was not cancer. My story would probably be very different if it were. But inside of it, kind of like a yolk in an egg, although much smaller than a yolk, was a cancer, an early stage cancer. And so I have a left upper lobectomy, and I've been watched. In fact, I just had a week of scanxiety because I just got my scans back last week, actually, and full body, and it was good. But a lot of similarity with what Sally was saying. I have. They believe that what I have was scar tissue carcinoma, which is extremely rare, and I don't even know if it would be susceptible to anything. It was caused by a mycoplasmosis pneumonia that I had like 16 years ago. And so I have a lot of nodules on the right side as well, but they're tiny and they haven't grown since 2006. So we're just watching them. But I don't know if we have tissue, but I don't think we've ever done anything with it because they said it was scar tissue. So I'm not sure if that even goes into the, gamut of could you do anything with it if you needed to. I don't know. But in the meantime, I'm very grateful. I feel great. I'm fine. And I like to be here.
Don.
Good evening. My name is Don Stranathan. I'm from Santa Rosa, California, stage 4 non-small cell lung cancer, adenocarcinoma. I was diagnosed in June of 2009, and I'm also with Kaiser, and at that time they weren't doing, all they found out was it was adenocarcinoma. So I was offered chemotherapy, Taxol carbo. I advocated until I got them to add Avastin to my mix. So I got the cocktail, Taxol carbo and Avastin, along with radiation. And then after that, I had Gemzar for some nodules in my liver, and my oncologist just handed me a bottle of Tarceva and said, try this. And I was fortunate, I received 6 years out of Tarceva, stable. And then in 2015, Over these years, I knew I had never been tested. So in 2015, in November, I discovered through a blood clot in my leg that I had a new tumor in my left lung. And I immediately said I wanted a brain scan, a bone MRI, a PET scan, and a biopsy done, and I wanted it sent out for multiplex sequencing. I reached out to Bonnie, and she connected me with a friend of hers, Deborah Morosini, in 2015. So I had a full panel done. And what was discovered was, even though I had been stable on Tarceva for 6 years, I didn't have an EGFR mutation. No EGFR, no ALK, no ROS1. All that showed up was an NTRK1 without fusion and a PIK3. So I reached out for a second opinion to a doctor at Mass General, and he said based on my history I should do very well on immunotherapy. So I went on nivolumab or Opdivo in beginning of 2016, and I was my tumor didn't grow for 36 or 37 infusions, and then actually I was down here in August at a living room, and Bonnie mentioned that, you know, side effects can be worse than the treatment if you don't report them. And I'm sitting here thinking, I can't breathe. So I went in, and they thought it was pneumonitis from the immunotherapy, but what it was that I had 3 liters of fluids in my periocardial sac. So they had to do periocardiocentesis and remove all the fluid. So I reached out to Krista again at Foundation Medicine, and I asked if they could test periocardial fluid, and they said if it was spun down, it was 20% tumor content, spun down to pellet or paraffin embedded, they could test it. And I just got that report back probably about 2 or 3 weeks ago. And what I noticed was I still have no EGFR, ALK, or ROS1, but I did have an EGFR amplification, which just means there's an overexpression of EGFR. So that was interesting. But what was very interesting was that they're now testing for tumor mutation burden. And I had a 2% PD-L1 expression, but I had 17 MUTS, which is intermediate expression of the tumor burden, close to high. So when there were malignant cells in that fluid, I had to be switched to another treatment. So I'm now on Genentech's new immunotherapy Tecentriq. So I'm, you know, knock on wood, the fluids haven't come back yet, so I'm just going one day at a time. Thanks.
And this is what happens when you're an educated patient. I'm serious. This is what happens, and this is the whole reason we do what we do. This is it.
He shares all that with everybody on Facebook.
Yeah, he does.
Mean, everybody on Facebook that has lung cancer knows Don, and it turns to him.
Yeah, exactly. We call him Dr. Spanish.
Hi, I'm Betty Corner, and I was diagnosed 3 years ago with adenocarcinoma. I had a primary in my right lower lobe. I'm a never smoker. I was in great shape, and the doctors were surprised, and I was surprised and a little disappointed. Let me think. I was about to have my right lower lobe removed, and the MRI found brain metastasis, and the surgery was off. But my doctor was encouraged that I was healthy and that the tumor was small. I went on Tarceva when they tested my tumor, and it was EGFR positive exon 21, and with CyberKnife and with CyberKnife and Tarceva, my cancer was fairly well controlled, and right then the guidelines were changed. So it was encouraged that if you had oligometastatic cancer, lung cancer, an aggressive treatment was recommended, which encouraged surgery. So I had my right lower lobe removed. So surgery was off, surgery was on, surgery, you know. But I did it, and it worked really well, and I'm still on the Tarceva. Last year I had one of the lesions appeared to be growing. They weren't sure if it was necrotic tissue, And the only way to really go in was to go in and look. So I had some brain surgery. Unfortunately, it was small. It was about 1 centimeter, and they missed it. The location of it was not what they were hoping, what she was hoping to find. And they decided to wait and see. But my last MRI shows that it has shrunk. And so it has become smaller, and my radial neurosurgeon believes it's necrotic tissue. So I'm very happy for that, and encourage people to not be despondent if you have a wait and see in your diagnosis.
Thank you.
My name is Hector Gonzalez Jr., and my father was diagnosed with lung cancer this July. And then we saw Bonnie's segment on Channel 2 News, and the next morning I reached out to Emily. I sent a pretty long, sad email, and a couple days later she responded, gave me some hope, and just listening to all of you guys here tonight, I am not educated at all, but I think I found myself in the right place. This is a tremendous opportunity, so I'm really, truly grateful to be here, and I'm getting choked up, as you can tell, but I'm really grateful for each and every one of you, so thank you very much.
Thank you.
Hi, everyone. I'm Tian Ho. I work for Genentech. Hi, Don. We spoke on the phone. I love coming to these just to hear all of your stories, and thanks for having me here.
Yeah, and I'm Nikki. I also work at Genentech, and it's an honor every month to be here with all of you.
I think we got it.
Do we have somebody outside?
Nope. Nope.
Okay, thank you. Well, you have a lot to do tonight.
All the answers.
But we're really proud that we call them our patients, are so well educated and know the process, because that's a huge issue out there in the big world, because not all of the physicians in communities, and maybe even some academics, are totally up to speed on a daily basis with all of the things that are available out there. So on that note.
Well, I think the most important thing for me sitting here tonight and having had 2 family members with lung cancer is how impressed I am with your knowledge, with your self-advocacy or your caregiver advocacy, both of those. That makes a huge difference in your outcomes, regardless of what else you do. But to educate yourselves and to learn what to do in order to have a positive impact on your care is amazing to me. So kudos to all of you. And I've heard some really good information about what you are doing to take care of yourselves. And I want to also, at this moment, also encourage you to, based on some of the information, keep pushing your insurance companies, keep pushing your healthcare providers to learn more about genomic sequencing and to make some of the changes that are going to impact your care and future patients' care. Because the more we learn about lung cancer and the more we know what each one of you has that's driving your lung cancer, the better we are able to help you. So I think based on all of the alterations that were discussed here, I'm going to just flip to another slide that we can just kind of look at as we talk through here. I heard EGFR fairly consistently. That's one of the most common alterations in lung cancer. Depending on the publication, it's anywhere from 10 to 25% of patients have some type of EGFR alteration.
Sherri, before you go into this,
okay,
I think everybody in the room and everybody online would love for you to explain. They hear comprehensive genomic testing, comprehensive genomic profiling. They hear deep gene sequencing. They hear molecular testing, biomarker testing. Can you kind of wrap all that up and and give them some input on all those different names.
Yeah, so those are all names for a variety of tests that are used to identify those alterations like EGFR or whether or not you'll respond to immune therapies. And there's a broad spectrum of tests out in the market. Historically, the first tests that were run were single gene tests, as we call them, where we would look at just EGFR, for example, or the pathology lab would test for KRAS positivity. And those tests require a lot of tissue. They're often a different type of test than the genomic sequencing that we look at today. And they don't give you a lot of information. So one of the wonderful things that has occurred in our lifetime is that we've understood more and more about the human genome, and with that understanding we've also been able to decrease the cost to run these types of tests. And so going from single marker testing, which was the normal test in the early mid-2000s, to understanding more all of the genes that are involved in cancer and having the scientific technology to test for those genes, we now have more and more comprehensive tests to identify historically in recent years through tissue and now with blood biopsies, we can identify what's driving the cancer. So single gene test, multiplex is another term, so 5 or 10 genes, maybe up to 50 genes, where the test is looking at spots that are known to be involved in cancer, but not the whole gene. So again, the gene, or the whole sentence, if you want to put it in that terminology. The methodology that Foundation Medicine uses looks at 315 genes. So that's a broad spectrum of genes. They also look at not just hot spot or single points on those genes to identify the alterations, but the entire gene. So it's I like to use the phrase casting the net wider. So you might have the EGFR alteration that's found fairly commonly, but you might have an NTRK alteration, which is very rare in lung cancer, but very targetable. So casting the net wide to identify what genomically is driving your cancer is going to be your best opportunity to identify treatments for that cancer. And so again, if you're having the conversation with your physician, they may say, oh, we don't need to do all those tests. We're just typically looking for EGFR or ALK, these lovely alphabet soup of genes. But what you want to do is say, no, I want to comprehensively look at what might be found in the tissue and is driving my cancer, not just the common or the easy to find genes or the easy to find specific alterations. And added to that, and this is complex, it's very new science. We're also now able to look at the type of gene alteration. So alterations in EGFR might often be a single base alteration. So you might have an L858R alteration, fairly common alteration, but you might have an amplification of EGFR. You might have an exon 19 deletion or insertion. And these are not typically found with your usual tests that might be in the pathology lab in the hospital. So again, casting that net across all the types of alterations within each gene that might be driving the patient's cancer is where we're at technologically today.
So what does a patient go to their physician and say, I want a comprehensive genomic test for 300 plus alterations?
Yeah, so I want a comprehensive test that's going to look at as many genes as we can. So in this case, 315 genes, and looking at all 4 classes of alterations in those genes in order to identify what's driving the patient's cancer. And I'll share a little anecdote here because I understand personally how difficult this is. It was just a year ago that I was looking for a neuro-oncologist for my son. So we were looking for the right oncologist. And in the first neuro-oncologist's office, I said, and I work in the industry, so I was able to say, I want comprehensive genomic sequencing and I want to run the Foundation test. And the neuro-oncologist said to me, oh, we don't need to do that. Well, that was the end of the visit. because I knew we needed to do that. I knew we needed to identify what was driving his tumor. And so I went to another neuro-oncologist who said, I don't know a lot about it, but help me understand what it is, and I'd be happy to order that test. And we ran the test and were able to identify the specific sequence in the genome that was affecting his tumor. Being able to talk to your oncologist and say, this is what I want, and this is why I want it, and I'm not going to take no for an answer, or finding an oncologist who understands better, who's willing to work with you. I'll take a step back and acknowledge that our oncologists, this is fairly new to them as well. That what we can do today, we couldn't do 15, 20 years ago. So even knowing what genes we're looking at is new to many of our oncologists.
So I think all of our patients have heard high mutation burden, PD-L1, EGFR, ROS1, HER2, blah, blah, blah. How do they decipher whether it is the 315 gene panel, does that include high mutation burden? Does it include PD-L1 and other markers that are known to be causative or a marker for immunotherapy?
Yeah, so we're very lucky to be in the era of immunotherapy. I think we're at the very beginning of it, and we're going to learn more and more about it. But the three methods that we currently use to identify whether or not a patient is likely to respond to the immune therapies is to look at PD-L1 protein expression, which is separate from this, but it's certainly run at our lab and most laboratories. The second and third methods are to look at what we call tumor mutation burden, which is an algorithm that we run on those 315 genes to identify whether or not the patient has a lot of mutations in the tumor, not just EGFR, for example. So we're looking at tumor mutation burden. We also look at another funky thing, microsatellite instability. And the part of the excitement right now is that microsatellite instability was recently acknowledged by the FDA to be a method to measure tumor agnostically, so across all tumor types, whether or not a patient might respond to the immune therapies. So PD-L1, tumor mutation burden, or TMB, as we call it, and MSI, or microsatellite status, three methods that are measured that you can get when you order the Foundation Medicine tests.
And TMB is pretty recent that you've been testing for that.
TMB is fairly recent as well. So those we had done as research tests previously, but in the last couple of years we've implemented those as part of the regular test report. And with that, we're able to generate those numbers that will inform whether or not a patient is likely to respond. And that's important because the immune therapies can be fairly toxic and they're very expensive. So we want to make sure we're giving them only when they're really going to help the patient. And I'm sorry.
That's okay.
I keep talking.
Yeah, that's okay. You're supposed to.
And this is an evolving field. We are learning more and more about that. And part of that comprehensive genomic sequencing, we're also learning that you may have a high tumor mutation burden, but there might be a couple of other genes that are found to be altered that are going to say that you probably are actually going to hyper progress as opposed to respond to the immune therapy. So you don't want to just get tumor mutation burden. You want to get that 315 gene analysis to look at those other genes. And we're seeing more and more evidence, it's been coming out at the last few conferences, that PD-L1 has been a nice historic marker for whether or not a patient will respond to immune therapy, but tumor mutation burden and microsatellite status might be more informative. So getting the TMB and the MSI are very important.
Okay, I have one more question about tumor mutation burden. Does the patient, the lung patient, have to have one of the 11 known markers, EGFR? Do they have to have one of those markers to be a candidate for immunotherapy, or can they have just a high load of markers that are not necessarily relative to lung cancer?
Yeah, so if they have a high tumor mutation burden, not specific to genes, gene EGFR or gene KRAS, but if their tumor mutation burden is high, they are eligible for the immunotherapy.
Okay, because I think some patients thought they had to have like an EGFR and an ALK and a ROS1, and that was the definition of high mutation burden.
No, the definition of tumor mutation burden or high tumor mutation burden is specific to the overall count, and it's calculated based on the number of genes that are interrogated, and it's very complex math. I won't bore you with it, but it gives you a number that says this patient has low, intermediate, or high tumor mutation burden. Now, to the point about do they have another alteration, there are combination therapies that are in clinical trials or in FDA approval that say when to get immune therapy as opposed to a chemotherapy or a targeted therapy and immune therapy. But TMB alone is a marker that's relevant for likelihood of response. It's not 100%. There's no 100% yet. This is still science. It's not exact.
Okay. Michelle, you have a question online?
I do. I have a few.
Okay.
So we'll start. So Susan wants to know, she wants to better understand the difference between proteomics, DNA, and RNA testing.
That's a very good question, and I wish I had a schematic because it's a little complicated. You learn this in biochemistry, so please feel good that you don't necessarily know this. Your DNA that I showed you the picture of, which is our building block or our blueprint for everything that happens in the cells, that's essentially telling the cells what they're going to do. That DNA is converted to another molecule called RNA. And the RNA basically translates the DNA to protein. And the proteins are the actual building blocks or the functionality in the cells. So when we talk about EGFR, there's the gene EGFR that codes for the protein EGFR or epidermal growth factor receptor. That's a mouthful, isn't it? So DNA is the copy that converts to RNA, which becomes eventually the protein that is doing everything from making us blink to take a breath, etc.
Michelle, you have another question?
What's the difference between an alteration and an amplification?
So an alteration is the generic term for any type of change in the gene. An alteration can be a single base substitution, it can be an amplification, it can be a large insertion deletion, it can be a change in rearrangement of genes. So there's 4 types of alterations. One of those types is an amplification. So the amplification specifically is when that gene is basically telling the protein to produce itself many, many more times than it's supposed to. Does that make sense?
Sort of.
just not our heads. Yeah, it's perfect. Got it.
No.
Yeah. Don't ask me again in 5 minutes. Sure.
You'll be tested.
Okay.
Okay.
Are we good?
There's a couple more.
Okay. All right.
Yeah.
Let's go.
How comprehensive is the liquid test?
Okay, so there are liquid biopsies, as we call them, on the market now, and they come in all different sizes. The one that Foundation Medicine runs is a smaller panel of genes than our 315 gene assay. It's 62 genes. And the reason for that, I'm going to just give you a quick picture here. I'm a proponent of pictures, if you haven't
I like
noticed.
pictures too.
So when we take a piece of tissue and we analyze it for any of those genomic alterations, we have about 20% of your tumor or of the tissue is tumor and the other is normal. So remember, only some of those cells are growing uncontrolled and they get mixed in with the normal cells. So 20% of that is tumor. So it's fairly easy to look at what's in the tumor and identify what's genomically altered. When we take a blood test and we look at it, only about 1% of that is from the tumor. So the blood, what we find in the blood is basically those cells that are being sloughed off as the cells are growing and dividing. Some of the DNA, fragments of the DNA, get into the bloodstream. So that's what we're looking for when we do a liquid biopsy or a blood biopsy. And because there's only about 1% versus that 20% that we can identify in tumor, we have to scale back, at least at this point, scientifically and technologically, to a smaller number of genes in order to get information back to the clinician and the patient in a reasonable time frame. We could look at all 315 genes still, but running the instrumentation to process that would probably take a week. And we don't want to take a whole week to get that piece of the puzzle taken care of. We want to get the information back to the clinician and the patient in a reasonable time frame. And to level set, reasonable time frame in the tissue diagnostic arena is about 2 to 3 weeks. We've gotten it down to roughly 10 days at Foundation Medicine, but know that there's a time process. So the liquid biopsy is a smaller number of genes because we're trying to stay within that same 10 to 12 days to get the results back to the clinician.
Okay. And then what is the typical cost for the 315 gene comprehensive sequencing? Louder. What's the typical cost for the gene sequencing?
So the Foundation Medicine test costs, if you look at the ticket price, $5,800. If you are with private insurance, they will cover a portion of it, and we have financial assistance for the patients. And I won't get into all the nuances with that. I want to focus on the science because that's what I am. But for Medicare and Medicaid patients, there's no cost to the patient.
Don?
I had a two-part question. You had discussed PD-L1. I'm hearing in a lot of recent articles that people with the ALK mutation, even though they have high PD-L1, that's not necessarily a marker that immunotherapy had worked for somebody with PD-L1. And then also, you had talked about hyperprogression. And I was wondering if you could tell me what you know about MDM2 and 4. I've been reading some small studies that if you have one of those mutations, it can cause hyperprogression with immunotherapy.
You're hitting on some of the key information coming out as we speak, and some of it is being presented at World Lung. So to first speak to the ALK rearrangement and PD-L1 positivity, and I should probably, halfway through the evening, let you know I'm not a clinician. so I will talk in more theoretical terms. The ALK rearrangement, and I shouldn't joke, but I joked to my husband that if I got lung cancer, I wanted to have the ALK rearrangement because the therapy associated with it is really good. We've got a great target that really targets just the ALK rearrangement and has been very efficacious in the clinic. So not knowing specifically what you read around that, I would say that the clinician is likely targeting ALK first because we have such a good correlation. It's an FDA-approved therapy. They're going to get a quick positive outcome without a lot of cost. Whereas if they also have a PD-L1 positive tissue, they may not respond to it. Only about 30% of PD-L1 positive patients respond to the immunotherapy. And again, the side effects are pretty significant, and the cost. So I think it all weighs into the clinician's decision.
And I think to Sherri's point is that's where the clinician comes in, to actually make an educated decision based on all of the different parameters that are involved in this. And they're not all the same because every patient is unique and different.
Right.
The MDM2 that I was asking about is actually, I have a friend, I think she's probably online right now, that was on Tarceva, and then when she had progression, they tried her on nivolumab, but because their tumor was in a hard position to get a biopsy, but later on when the liquid biopsies came out, they did test her and she was T790. So she went from Tarceva to Opdivo and then to Tecentriq, and all of a sudden she started having hyperprogression, and she does have that mutation in the MDM2. So that's one of the reasons I was bringing that up.
So the studies are ongoing, and I think we'll see more and more data as the year unfolds. But MDM2 has been associated with hyperprogression in patients on immune therapy.
But this is all information that is new, and we didn't have, we were talking about outliers just a year ago and 2 years ago. The ones that perform really, really well for a long time and the ones that have hyperprogression. But the more and more research that happens with all of this gets us to, more laser-targeted treatment programs.
And that's one of the unique features of Foundation Medicine, which is that we have tested over 120,000 patients, and we can look at the patients that have high TMB and what the patterns and the other alterations are, and then the association to whether they responded or hyperprogressed or had just a lack of response. And we're starting to see these patterns and these different alterations that are actually driving the field forward, and hopefully in the near future will allow us to be able to say, if TMB high, but MDM2 positive will likely not respond to treatment. And the FDA is watching all of this, and they're going to make some decisions about what they put in the label based on this.
Yep. I think we talked about this quite a bit, but can you talk about the difference between a tissue test and a blood test?
Yeah, so to the graphic behind me, the first difference is that in the tissue you get about 20% tumor versus in the liquid you get a very small percentage. So the standard of care is really, if we can get a biopsy, it's best to get a tissue biopsy, because we're going to look at more genes, we're going to get that tumor mutation burden, and we're going to get more information about the tumor. But a patient is not always a viable candidate for a biopsy, and that's when a liquid biopsy comes into play. We can get some information from a liquid biopsy, hopefully sufficient information to determine treatment options. A liquid biopsy then comes into play upon progression in lung cancer or recurrence, where we already have data on what was driving the cancer previously. And one of the examples, I can't remember who had EGFR and then a T790M. Was that? Anyhow.
No, but that happens frequently.
So EGFR alterations like EGFR L858, exon 19, 20, 21 changes, et cetera, we give certain anti-EGFR agents to. And at a certain point, cancer is very aggressive. It's going to find a way around that treatment. And it's going to find what we call resistance mechanisms. So we often see in EGFR positive patients who've been on an anti-EGFR agent resistance alterations. And the most commonly found is that T790M alteration. So if we are using a liquid biopsy on a patient who was previously EGFR positive, that EGFR, let's say L858, has disappeared from their tumor, but now T790M is showing up, we can identify that in the liquid biopsy. The important thing in a liquid biopsy is not to just look for T790M, because 40 to 50% of the patients will have a T790M resistance marker, but the other 50 to 60% of the patients, I think I did my math wrong. Sorry about that.
It's okay.
The other portion of the patients who do not have that resistance alteration are going to have another alteration. So again, casting that net, finding what else might be involved in that patient's progression. And using our liquid biopsy, we're looking at that entire EGFR gene. We're not just looking for T790M.
So I'm trying to stay on track, and we have some questions, but you're answering them before we're asking, which is awesome. But one of the questions was, at times we see the T790 in blood before tissue. How common is that?
Well, I can't quantitatively say how often we see that, but we can see it in blood before we see it in tissue, because again, in blood we're looking at a pretty small amount, and so we're able to dial in our viewpoint to roughly 1%. So if it's at 1%, we can identify it. Whereas when we're looking at the tissue, if it hasn't grown in enough of the cells, if we don't have that new alteration in enough of the cells, say it's only in 10% of the cells in the tumor itself, we might miss it because we have to have a cutoff on our limit of detection. So it might be counterintuitive, but we can find some of these alterations that we identify at progression at a very small concentration in the blood that is going to take a higher concentration in the tissue to be visible.
And to that point, we're seeing quite often actually patients that start with one marker, say an EGFR mutation, and then progress and have another marker.
Mm-hmm. So using that EGFR example, if a patient has an L858 alteration and they're given that anti-EGF drug, the cells with that alteration being targeted specifically are going to die. So you'll see fewer and fewer of the molecules that have that EGFR alteration in it. But the cells that are still growing that either didn't have that alteration, or the few cells that have escaped through a variety of DNA mechanisms, now might have a new alteration. Often it's going to be these resistance ones like the EGFR T790M, but there may be a small group of cells that was quiet previously, but as the larger number of cells have died off, they have the opportunity to grow, and they might have a different alteration that now essentially takes over and allows those cells to become the majority population.
You have a question?
Yeah, I do. It's a little bit along those lines of finding it in the blood, but it's a question we get a lot from patients who maybe had surgery. They're going in, the scans are showing. Francis mentioned, being clear, but you're always wondering if something is there. Tina mentioned she's in a study right now where they're running the test to find out what's going on. Sally's had surgery. And a question I get a lot from those patients is, are we at the point now that they could go in for a blood draw and have something run and use that to monitor and see something is growing potentially versus going through a scan or something along those lines? What's going on? Can we find it sooner? It comes up a lot, and I think it'd be great to address that.
See it before you see it on a scan.
See it before you see it.
Well, there have been anecdotal stories about that, but I will say that we're in the active research phase with identification of progression before we see it on a scan, and with identifying cancer before we would know that we have the cancer, right? So, I mean, our best goal would be to get to a point where we can go in yearly to the doctor, get a blood test, and they can tell us right away rather than when we get to stage 4. Because we can do a lot more at stage 1. But the research has not reached the point where that's a viable commercial method of monitoring whether or not your cancer has returned or whether or not you have cancer. What we see, and again, this is kind of relative to the graphic I have up, which is you have to have enough cells that are actively growing for that DNA to slough off, get in the blood, and be measured. So typically, a patient who has one very small new nodule is not likely to have that tumor identified in the blood. It's typically what we call disease burden. The higher the disease burden, that we get more information. Although, again, with the complexity of the biology, this doesn't always have a real clear, cut and dried ability to say the nodule's too small, we wouldn't have seen it, or you have 10 nodules, why didn't we see it? So that being said, we're getting there, and I am very hopeful that in the next 10 years we'll have the opportunity in our doctor's office to get a blood test and know whether or not we're progressing before we get to scan.
Can you see blood testing happening more? David Gandera did a talk in here a couple years ago, and he talked to all the patients on who's driving the bus. And his analogy was a bus and a driver, and it's going down the road, and that driver happens to be EGFR, right? And then gets a little bit further down the road, EGFR gets off the bus, and another marker gets on the bus. So do you see blood testing being able, if we do it more regularly and can get it more cost effective, if we do it more regularly in the patient's treatment process, that we could actually find that new driver before we see it on a scan?
Yes, I think we are very close to being able to do that.
Okay. That's really good news.
Yes.
Really good news, because, you know, tissue is invasive and difficult, and
biopsies are no fun.
Yeah.
I don't say, hey, I'd like a biopsy today.
Right, exactly.
You know, I don't like blood draws either, but they're less invasive.
Right. And that could be the difference in staging as well. You know, if you start out with a patient that starts with a marker at stage 1, and you find it before it turns into a higher stage with the blood. So that's all very exciting stuff.
I want to make sure we pause just to make sure there's no questions from the audience or some of the things that they had talked about earlier that they might want to get a little more information on, and then we can get back to our list too.
Yeah. Lost Michelle.
I've got one.
Yeah, okay, please.
Do you get feedback from patients? Because usually when I came in for my test 2 years ago, I sent you my sample and you ran the test. Do you get feedback from the customers, the clients, on how they responded to their treatment plan?
Well, that's a great question.
We have not actively collected it. We are working toward active collection of the clinical data behind each patient. We get data from clinicians who are actively writing up their patient experience, for example, or we look at cases that have unusual alterations and call the physician and ask them how the patient responded. Did they put them on the specific therapy? How did they respond to that sort of thing? The goal would be to ultimately have clinical outcomes for every patient, because the more we understand about whether or not a patient hyperprogressed or had a response, the more we can add to the genomic data the clinical piece, because that's really where we want to get. We want to take the genomic information and apply it to what happens clinically so that we can go back and make changes to clinical care based on what we now understand about the genomics as it relates to the clinical outcome.
Great question.
Do you have any idea how a patient can have these discussions with their physician, especially when their physician is not an expert in this field?
I think I touched on some of this earlier, and I think the most important thing for me to recognize when I've been in the oncology office is that a lot of this is new to the oncologist. So give them a break, but push them. So know that they're learning this and they're trying to do the best for the patient, and they might be limited with the confines of the insurance company or what their hospital system is requiring them to do. So educate yourself, educate them, keep asking them why or why not, and just keep that dialogue open with them. I think that's the best thing to do.
Does Foundation Medicine have an 800 number or something that a patient could call? And I'm serious about this because this is a huge issue for patients. I mean, they're the ones with the cancer, and they're the ones that need the treatment, and they're the ones that need the right drug at the right time. So we can't be, you know, babysitting our physicians.
Right.
We need to be sure that they're giving us the right treatment at the right time. You know, when the report comes back, it's fairly easy to read. Patients are given the report, and if you don't feel like your questions are being addressed based on the information on the report, is there an 800 number that a patient could call to get more clarification?
We do have an 800 number. We typically talk more to the physician than to the patient, but it's not because we don't want to talk to the patient. It's because the physician is usually the one who's calling to ask the questions. And often there's that two-way dialogue with your physician. I've got the report, you've got the report, tell me what it means, what does it mean to you, how is that going to impact my treatment? We have MD consultants who talk to the physician, so I often facilitate calls with an oncologist oncologist who's gotten one of your reports and wants to understand better what the interpretation on that report is. So they call into Foundation Medicine, and we connect them with an MD who has treated, let's say, in lung cancer and has some experience and exposure to the specific therapies. And so there's a dialogue that helps the oncologist to understand better what to do. If a patient has questions and the oncologist is not answering them well, I think our client services could probably answer some of those questions. We aren't trained specifically on the patient side, but the other piece to it would be if you're not sure you're with the right oncologist, it wouldn't hurt to call Foundation Medicine and say, I'm in this area of the country, who are the oncologists who are ordering Foundation Medicine, because I'd like to talk to them.
I think Michelle had a question.
Yeah. Yes. What kind of tissue would work for a comprehensive genomic sequencing test?
What size, maybe? What?
Yeah, I mean.
Yeah, so I can answer hopefully most of the aspects that would encompass. So if you get a tissue biopsy, we require a very small amount of tissue, and the department that takes that tissue after surgery and they put it into what's called an FFPE block, and a very small amount is needed. We really, once that block is cut into slides that are used, not to get too much into the technology weeds, we only need 10 slides. So that's one of the pieces of it. So very little tissue is needed from the patient in order to run this test. One of the difficulties in this industry is that often the clinician will order EGFR by IHC, for example, and that uses 2 or 3 slides. And then if the patient's negative, they might test for ALK or ROS next and use up several more slides. And then by the time they get to, the patient isn't positive for the top 2 or 3 alterations we're looking for, the tissue has all been used up. So the goal is to go immediately to this more comprehensive genomic sequencing to get, again, a larger number of genes analyzed with very limited tissue.
So this points to the importance of rebiopsy. So how often or when should a patient's tumor be rebiopsied?
It's a very common question. So if a patient is doing well on therapy, there's certainly no need to re-biopsy. If a patient has done well and they are recurring or they're progressing, that's the point at which we ask the question, do we need to get a biopsy of what's driving the tumor now, or do we need to do a blood biopsy? So those are 2 ways to look at it at that point.
Do you know when an oncologist might be reluctant to order comprehensive genomic testing? Should there ever be a reason to not do that?
I don't personally think that there's a reason for that.
Thank you, because neither do I. Neither would I.
I'd like to do a follow-up on that, if that's okay.
Okay. As soon as I say
yeah,
yes,
you go ahead.
Because the patients are paying for the test. I think if they want it, they should get it.
Absolutely.
So mine is going to move a tiny bit away from the science, and the good news is you have a lot of really smart people on your team here who might be able to answer in case you don't know for sure. But one of the challenges we see, in this room we are fortunate that the majority of the people had testing. We know that's not the case. So what are the challenges you're seeing within kind of the space to get physicians aware, to get patients aware, to really increase those testing rates, because we do know it's so important if we're going to be talking about personalized medicine to have this information?
Yeah, so the things that I think my colleagues can attest to, I'll start with a little bit of it being clinician-facing often, which is the concern about the finances for the patient. So they're legitimately worried that you're going to have one more cost incurred. So at Foundation Medicine, we eliminate that barrier. We do not want finances to be a reason not to get the tests that would get you to the appropriate therapy. There is often in-house testing, and they might run EGFR and then ALK in-house, and so there's reticence to do the comprehensive profiling before they've done their in-house testing. So that's another pushback that we often get. So I went blank, so I'm going to throw it over to you guys.
Okay.
What are other resistances?
I think part of it too is physicians who've been, doing this for a long time weren't necessarily trained on genomic testing, and so, new companies and new technologies come out, and we go to a physician and say, "Hey, I know you're a great physician, and you've been doing this for 20 or 30 years, but let's take what you've been doing and kind of flip it on its head and do something completely different, and avoid, standard of care, but look for a genomic picture instead." And it's an education thing. Physicians are incredibly busy. Many of them are seeing 20 to 50 patients a day, sometimes depending, and just their ability to take the time to learn new things or to differentiate between different tests. There's multiple people that are vying for all vying for their time, and like Barry said, there's institutional parameters and internal tests and different things that they have to abide by. So it's a challenge for physicians to really balance that all out, and it really comes down to an education thing, I think.
And they may have had a bad experience 10 years ago before this technology was sufficient to really get the analysis that we do today. And you have a bad experience and you lose a patient and you're hesitant to try it again.
I also want to say that, in the community setting, most oncologists are they're doing all kinds of oncology. Mm-hmm. I mean, to have someone who knows lung only, that would be really rare in the community setting. I know Kaiser in Sacramento is experimenting with that, where they have just doing lung or just doing bladder or breast, and so that's really hard on them. And then the other thing that's hard on them is that if it's not in the NCNN guidelines, we can't do it because it's not covered. And so getting those guidelines established that's an option for coverage or for protocols is a barrier, I think.
So that was because I had a follow-up that's a perfect segue into, and that's, you have a group of patients who obviously are educated. They're people who are interested in being advocates and pushing, and obviously you're speaking at a foundation that's interested in this. So what do you see are some of the steps we as a foundation could take? What do you see some of the steps that patients could take to try and increase this knowledge and increase the use of these tests? Again, putting you on the spot, but we're going to steal your answers and use them.
I think certainly advocating with your insurance companies, advocating with the government. So one thing that we haven't touched on tonight is the 14-day rule, and I think that needs to be changed because for those of you who are not aware, a patient goes into the hospital and they're a Medicare patient, they have to wait 14 days to get the test performed. And my uncle was a victim of this last November, where they waited 14 days to get the tissue to perform the test, and at that point he was too far gone. And so we need to change that rule. We need to be able to get this testing done within the first 14 days of diagnosis and not wait for those Medicare patients. So that's another piece to it.
And it's discriminatory.
It is absolutely discriminatory, and your voices are the most impactful because you're living it and because you don't have a commercial entity behind you that they perceive as biased. So getting your voice heard, getting out there, getting obviously the Bonnie O'Dario Foundation is incredible. You guys are doing a lot of this work, but continuing to do it, having the conversations with your physicians, with the administrative staff at your hospitals. Just keep talking and keep pushing for what we need.
You have anything else, Michelle?
I have a question over here.
Oh, okay, I have. Did somebody have a question?
In the back, yes.
Oh, okay.
I'm sorry. I was not tested till it was established I was stage 4. Are people testing sooner now? I just met a woman who was stage 1. She had her surgery. She was done. I asked her about her testing. She didn't know anything about it. She just knew she was there and she was done.
Yeah.
And lucky, she seems pretty good right now. But is that changing now? Are people doing that testing any sooner than stage 4?
People are definitely doing that. Unfortunately, in lung cancer, the majority of patients are identified at stage 3B4. So they're already pretty later staged. But earlier testing can certainly inform treatment options after standard of care.
And there's quite a few clinical trials going on out there right now on early stage surgical patients actually being tested and being followed more comprehensively. It used to be where an early stage lung cancer patient got surgery and just was sent down the road. No follow-up, no after treatment, so yeah. But it's slow going. Can you talk to us about genomic testing and clinical trials? We're not starting to run out of time yet. We still have 36 minutes. But clinical trials to me are extremely important. And I'm a huge proponent of clinical trials. And sometimes a clinical trial may be the best first-line therapy for a patient. Can you kind of address?
Yeah, so the approach to clinical trials is changing, and we are seeing more and more clinical trials that are actually utilizing the genomic sequencing as a basis for inclusion into the trial. And again, if you look at a larger number of genes across all 4 types of alterations, you're going to have the option to identify more alterations that might inform specifically a clinical trial that you might be eligible for. So again, we're casting the net not just to FDA-approved therapies, but clinical trials, so that you have more options available to you if we identify an alteration, like this NTRK alteration. It's an up-and-coming alteration that is being fast-tracked by the FDA, because even though it's in a small percentage of patients, in clinical trials with NTRK positive alterations, they were able to really identify a targeted therapy that is going to go from clinical trial to FDA approval status. So that's part of it. Identifying these alterations, as a field, we're better able to identify the alterations than we are able to develop the drugs. And the clinical trials help us to develop the drug that is eventually going to be there for the patients enrolled in the trial, and then the next generations of patients.
To David's point about community physicians and the reluctance at times to do certain things, and they're busy and all of that. What can we do? What is our role when patients come to us and say, I asked my physician and he or she just says no? What can we do as a group of needy people? I'm serious. Pick it. Pick it. What can we do?
I like that idea.
Yeah, because, 80% of all cancer patients, not just lung, all cancer patients are treated in the community arena. And I can only dream, because that's a huge barrier. So I just have to dream. What would this all look like if all of those physicians were giving comprehensive genomic profiling right out the chute?
Yeah.
All of them.
So moving to getting the physician on board, building that bridge with the physician, as opposed to just walking away. If you like your physician, say, can I bring somebody in, me, to educate the physician, to help them understand why it's important and how it's impacting patient care. I think that's huge. So educating your physician, I know it seems a little counterintuitive, but again, this is the first full decade of genomic profiling that is being available to the clinician. I was at ASCO last summer, and a first-year fellow said that this is the first year they're really bringing it into the medical schools. So be patient with your physician, but be forceful. If they say no, tell them you won't take no for an answer. You'll help educate them, whatever you need to do. But the more we can educate ourselves, educate our whole families, and the education will just eventually get to everybody, and the physicians will eventually come around.
Well, I would personally love to see Foundation Medicine and other entities that do genomic profiling on major TV shows and, Good Morning America, and talking about this. I think it's huge if 80% of the cancer population are not getting what they should be getting and what they deserve.
I agree.
So I have a question from Danielle. She texted me, asked me. She mentioned that Sally and Ina both have tissue from when they were first diagnosed. And isn't there a place where they could send their tissue to a study such as Castle? So they're going to give us a little plug. So it would be more beneficial and help the future of science. And wouldn't it be interesting to find out what their cancer had to say when they were originally diagnosed compared to now?
Well, Sally was in the ILCAP program. That tissue's out there somewhere, Weill Cornell, actually. And what hospital did you get your test in? Because they have the tissue.
No, I checked because I know one of the head nurses, and she checked with the oncologist, and they said they had the tissue. But my oncologist's point was, I was almost at the 5-year mark. And he felt that if they tested the tissue that was there now, that wasn't necessarily what was going to be if another nodule grew or another primary was there. That's why he was saying that if I had a new primary or one of them grew and they biopsied it, then he would definitely do the testing on it. But the fact that I was almost 5 years out, he didn't feel it was worthwhile to do it on the original tumor.
So it's a research question if you have older tissue and more recent tissue to see the differences between the two. And unless you've had targeted therapy, it will likely not tell you anything about changes genomically that cause the driver to go away. But if a patient only has tissue from 5 years ago, if they're not amenable for a biopsy, it's often worth testing that older tissue or getting a liquid biopsy.
So I'm 8.5 years out now. Is it still beneficial to do that?
If there are questions about your current status, so if you're progressing or recurring, then it might be worth looking at it. Certainly, if you don't want a new biopsy, you could have that tissue run and do a liquid biopsy at the same time to see what you can see.
Well, believe it or not, I didn't have a biopsy.
Okay.
They were so sure through the ILCAP and through the thoracic surgeon and pulmonologist I was originally sent to. They felt with my family history and the fact that I had been a smoker, even though I had quit many years before, that there was no question that it was malignant, but that they felt it was small, they were getting it early, and they didn't see the need for. And I thought I knew so much because I'd gone through it with my mother, I'd gone through it with my uncle, and I was pretty brass about it. Oh, I know more than the average person. I didn't know a thing because things had changed so since my mother had had it last. So anyway, that I never had a biopsy. I just have the tumor that they took, and I assume they still have it at El Camino. But I mean, I can find that out. But my oncologist's point was that to wait if then one nodule they were watching it's only 8 millimeters. If that grew, then they would biopsy and they would have it all tested. So does that make sense?
Yes. If you have a new growth, biopsying the new growth is the most relevant to how to treat the current cancer.
Andrea, I think you had another one?
Yeah, so I definitely have another question, but I think what Danielle was referring to is, Mom, when you were first diagnosed, they obviously resected and you obviously have tissue, which later on they don't have because they can't find it. But we originally wanted to collect that tissue to put it into a study so it would help future research. Not necessarily for you. I mean, it was kind of a twofold, for you, but then also for future research. That tissue is so valuable for multiple studies.
Okay, well, yeah, we have a second foundation. It's called Alchemy at Area Lung Cancer Medical Institute. And we actually have a collection of stage 4 lung cancer tissue that our partners have shipped to us, and it's in a biorepository. And we do share it with for research projects. And we've talked about bringing in community hospitals to be part of that, because community hospitals, and somebody correct me if I'm wrong, you know, they need to have the tissue for pathology, but they don't necessarily keep the tissue for an extended period of time.
By law, they have to keep it 10 or 15 years. I don't remember the current requirements, but it's not discarded.
But do they have the facility to really keep the tissue that long and keep it?
So they're typically in these FFPE blocks, and so they can last indefinitely. We have, as an industry, tested the viability of these samples over the course of longer and longer time that they've been in storage, and the data suggests that 5 years is typical. You're not going to have a lot of degradation of the sample. 10, 15 years, it's probably not very useful.
Okay.
I think one of the things that's unique about our Castle study is not only are we getting the tissue, we're also getting serial blood with that as well, and we're collecting all the clinical and corresponding data that goes with that. So if someone was looking at doing a research study on it, not only do we have the tissue available, we have blood available for those to kind of compare in some cases, and then also the clinical data. So I think that's a big part of what Danielle was alluding to, is just trying to expand upon that, and not just have the tissue, but also be able to make it available for research in a bigger way. I can't remember, I think you asked the question about the research with the tissue and doing those things, and being able to really dig deeper. Do we know what happened with these patients once they were tested? Do we know if certain patients, because of what would maybe have been there, now 5 years out, they had a much better outcome to find those outliers?
Yeah.
So what other things can we do to build, or what can happen within the industry that might help us start answering those questions?
Well, it's hard to really collate all the clinical data just
to do it?
Yeah. It's a lot of work. When I've done registries previously, it's easily 2 to 4 hours going through the medical records at the computer and trying to input it into the system, and we often are not asking the right questions just in general. So, and again, what Foundation Medicine is working toward is an ability to collate the correct clinical data into populated areas of the right questions, so that we're going through the clinical data and identifying the information that's needed, and not putting in 100% of the information, because not all of it is going to be useful in the analysis. So working with Foundation Medicine to perhaps collate the data that you have, is it in the Alchemy study? Might be a really good way to start to put together the story behind the genomics of the patients and the outcomes of the patients.
Because in stage 4 patients, rarely do they have surgery. So there aren't a lot of core biopsies from stage 4 patients available to do that with.
Often the fine needle aspirate will have been pooled into an amount and spun down, and the cells from that put into an FFPE block. So there still might be a way to get to it. Looking at blood, the liquid biopsy, that blood, we can't take stored blood for that particular test. It needs to be within 7 days of draw. But it might be a study that you look at in having the patients get tissue and get blood, run both tests simultaneously, and then follow them prospectively to see the outcomes based on the therapies.
What's it going to take for us to make genomic profiling standard of care? What do we have to do? Because, you know, I see all this direct to market now. You know, and patients are very educated about immunotherapy only because it was on TV.
Can I ask on that one as well? It's associated. To what extent are you communicating to the National Institute of Health to make that a standard protocol? Genomic testing needs to be a standard protocol.
So it really comes to the National Cancer Association, the NCCN, as opposed to the NIH. The NIH is more focused on the research and the clinical trials. And they buy into it in that they've done some of the early studies that have helped us be able to do what we do today commercially. I think it comes down to education, lobbying to the government and to the national organizations, and lobbying with the insurance companies, because a large portion of the pushback we get is the inability to get it paid for by insurance.
And you know, our people are very educated, and I mean, they know what to ask for and they know what to do. But most patients have no clue when they get into that office and they're told they have cancer, any kind of cancer, what to do, you know, or to even ask for this test. I think we have to get out there in a big way so people know what to do in the event they need it somewhere down the road. Like immunotherapy. We're spending millions, probably billions of dollars for these TV commercials. Why can't we do one for genomic profiling so patients know to ask for that upon diagnosis? That's what we need. I mean, that's the only way we're going to be able to educate people. We can't keep doing it one by one by one by one.
I have personally seen the impact of the commercials with the immune therapies. It's been good on two fronts, right? We've had great outcomes for the patients, and we've had patients who are asking for information on how to get on immune therapy, unlike the educated
which
group
involves
here,
genomic profiling.
Right? So unlike the group here where you're educated, you know, when my uncle was diagnosed last November, my aunt called me and she said, "I saw Keytruda on the TV."
Right.
So, you know,
Keytruda.
Yeah. so it definitely is impacting, and as we continue to evolve the known markers around the TMB value, for example, like the MDM2, as the clinicians become aware of that, they're going to understand better that they need a more comprehensive test in order to determine the best whether or not the patient is going to do well on immune therapy. So it's another avenue that's going to slowly move the needle. But yeah. Television gets us far.
Yeah.
Do you have a question? Can we get a mic over?
Oh,
again?
you need a mic, Esty. And hold it up close.
Okay.
There you go.
Okay. If you have spots, because I had my surgery 14 years ago, and they have the block at Stanford and so on. You said 10 years. If it's 10 years old, there's no sense doing any more testing on that block, correct?
Well, it's got less potential to be viable, but it can't hurt to try.
Yes.
I would never throw it out.
Well, they have it, 14 years. Well, I'm curious about, does it pay to do genomic testing when you have all these spots? They call them ground glass. They don't know what they are, but one of them didn't look right to them, and they did the targeted knife,
CyberKnife.
Yeah, they targeted radiation on it. And they say they think they killed it. Does it pay to do a genomic testing to see if any of the other spots that I have that you cannot biopsy because they're too small? Is there any test that you could do to see if there's any value, any other way of finding out is there anything wrong with those other than the CT scan that they do periodically?
But what Esty didn't tell you is that about a year ago she had a nodule that was...
Who did?
You did. You had radiation.
Yes, I had targeted radiation with linear accelerator.
Right. And that would have been a great time for a blood test.
But I didn't know because I don't have an oncologist. I used to go to Heather Wakely, and I don't know, she's busy now with a lot of stuff, and I decided. So I just see Dr. Lou, what's his name? Lou.
Your radiologist.
My radiologist who did the targeted radiation.
Yeah.
And that's quite a job. It took 4 hours to just put you in a little coffin, and they had lasers on the ceiling and so on to get that little spot that they weren't 100% sure that it was malignant, and it was too small to do anything to it other than to kill it. So what about the other spots is what I'm curious. Should I do any genomic testing or...
Well, again, I'm not a clinician. What I'm hearing is that they are not changing, and so there's probably nothing to worry about.
So if one change, they just kill it one at a time if it does. But knowing in advance, if you did genomic testing, maybe you find it earlier? I don't know. I don't know enough about it, so that's why I'm asking the question.
So we're not at a point in testing that we can do early detection of cancer.
Oh, I see. So you can't see anything early enough to see.
Well, that's on TV too. I just saw it yesterday. Hospital here says we can find it in the blood.
They could find it
early.
In the blood? Early?
So there's early studies with circulating tumor cells that they're starting to identify in the blood, but it's not something that is available nationwide right now. If you want to reach out to them and see if you could participate in their clinical studies around that.
You have to have a clinical study. I mean, what if you pay for it yourself and not worry about insurance?
I'm not hearing that your spots are big enough to get enough tissue to analyze.
Are you talking about a blood test?
I'm talking about the ones you cannot. You have to get the tissue. You have to do a biopsy to analyze it. So I guess I didn't understand how it all works.
Yeah.
You have to biopsy the spots.
Yeah.
Okay. This is all new to me.
Yeah.
I'm sorry.
No, that's great.
I didn't
That's
know.
I'm sure other people have similar questions.
Yeah,
so,
exactly.
Michelle, you had someone online?
I do. So someone would appreciate knowing your stand on RNA and proteomics testing not in lieu of, but as well as DNA testing.
So the DNA testing has really been, in a way, the low-hanging fruit. The majority of the information that we know about cancer is from the genome, from what is happening at the gene level with cancer. Sometimes we can see information at the RNA level, so changes in the RNA, and that also can be seen for lung cancer if we focus on, and I'm not going to get into the biochemistry, but if we focus on areas that are known to have changes with the RNA, we are testing those with our assay. And for cancers that there's a lot of changes in RNA, we can identify that using our foundation, or our other assay that looks at more RNA sequencing, and that's typically the hematologic malignancies. Protein expression is another test. So again, DNA to RNA to protein. The protein that's most commonly tested in cancer right now is the PD-L1 protein. And again, you can look at PD-L1, but it's often negative and TMB is high, and those patients are responding to therapy. So the protein tests are a mixed bag because if you think about your cells and what they're doing on a daily basis, the protein is the actual working, the functionality of it. And depending on the time of day, what you've eaten that day, if you've exercised that day, those protein levels might go up and down. So it's harder to get a real clear measure of a protein expression level that might be impacting your cancer. Whereas the genome, the gene piece has already been changed, and that's static. It's not going to change over the course of that day.
Ron?
I have a research question. So many of the trials out there right now are doing combinations, immunotherapy A with known drug B, or sequencing this, immunotherapy with something. So lots and lots of immunotherapy trial combinations. but nobody really looking at, from what I can tell, why are we throwing the spaghetti on the wall to see what sticks? Why does it stick at all? Is there much research going on into just the fundamentals of these protein alterations and these immunotherapies? Why do they work at all? Can you talk a little bit about that?
Yeah, and I think there's a couple of different questions in what you were describing. The combination therapies are an attempt to really stop the cancer in its tracks because, as I mentioned, cancer is ingenious in finding ways around the therapy. And in our body, there are multiple pathways of functionality going on at the same time. And if you have an alteration in a gene that's impacting a pathway over here, and you target that, the cell can find a way to get around it and go down another pathway, essentially. So the combination therapies that are being tested now are ways to try to stop two pathways at the same time. We have probably found a lot of this gene's altered, this is the therapy that stops it, and now we need to look at more combinations, more ways around it. Specifically to the immunotherapy, I think we've just scratched the surface. The immune therapy that is working now is all centered around the T cells, which is just one piece of our immune system. Our immune system is immensely complex, and there's multiple layers to it. And so we've been able to identify with the T cell, which is basically, the T cell is surveilling the body. It's looking for foreign bodies. It's trying to find what shouldn't be there. And when it finds something that shouldn't be there, it upregulates the immune system to attack it and remove it, as if we have an infection or that sort of thing. So the cancer is able typically to mask itself. And so when the T cell's looking, it goes by the cancer and it doesn't recognize it as foreign, so it doesn't upregulate the immune system. So this is the specific way these current immunotherapies are working. Well, there are other layers in the immunotherapy that we will likely continue to research and evolve and develop another set of therapies later on. But these are the ones that are working in a subset of patients currently. So as the research continues to grow and the understanding around all of the complexities grow, we will likely get more types of immune therapies that work. Did I answer all your questions? No.
So, Rana, I was fortunate enough this year to be one of the people who got to review a lot of the abstracts for the World Conference on Lung Cancer, specifically as it related to immunotherapy. And while I'm not anywhere as well trained in terms of being a scientist, I've learned enough that I could kind of get an idea and be able to look at these and make some judgments about what should be presented, what was something that should be in a poster. And I can say there is research taking place into some of the questions that you're asking about. I think it's still early in the game, to be honest with you, on those. But there are some smart people out there starting to ask those exact same questions that you alluded to, which I think is promising. I agree with everything you had said, that I don't think we yet know why things are working. We're just trying these combinations. But there were a lot of papers written. And what was interesting is many of them, because it is the World Conference, there would be one from the US on this topic that was exactly the same as the UK, which is exactly the same as from someone in Asia. And people are asking these big questions of trying to figure it out. So I'm hopeful we'll start to see some of that, those questions and papers and work come to fruition and give us a better understanding. Yeah.
Thank you, David. Can you talk about CAR T cell a little bit?
I don't think I have enough background in that, so I apologize, but no.
Okay.
Danny had a question?
I have a question, Dr. Willis. We all are talking about profiling, but I think the conversation has always been around the damaged genome, correct?
Mm-hmm.
So are we doing any profiling, or is the space moving in the direction where we can do familial profiling, right? So when you happen to have this as your day job, I learn about my best friend who I see every day, and she says, oh gosh, you know, my grandma died of lung cancer, but she was a smoker. So then the conversation ends, right? So, I mean, are we looking at it from the DNA level and profiling propensity? as we have in some other cancers?
Yes. So there are a subset of cancers that are known to often be familial based, and I think a lot of the press came around Angelina Jolie, who really, I think, helped the understanding of the field by being BRCA positive. And so I'll use the BRCA alteration as the example. BRCA1 and BRCA2 are two genes in the DNA repair cycling. So going back to my first or second slide where I showed the DNA, one of the ways that the DNA damage replicates is that our repair mechanism isn't fixing it as it comes through that replication machinery. And BRCA1 and BRCA2 are well-known alterations that are inherited that cause most frequently ovarian and breast cancer. We now know that there is a subset of patients with prostate cancer and pancreatic cancer who are also familially BRCA1 or BRCA2 altered. So there is an understanding that there is some predisposition to cancer. Not all of the predisposition is well known because of penetrance, which is a term that just means the risk that you will get a cancer. So you may have a BRCA2 alteration, and so your penetrance or likelihood of getting breast cancer or ovarian cancer, breast cancer as a man or a woman, ovarian cancer as a woman, is high, but your likelihood of getting pancreatic cancer is not quite as high. So looking at what we do, we are focused on what we call the somatic alterations, the alterations that are just found in the cancer cells. But as I mentioned, 20% of that tissue that we have is from the cancer, and roughly 80% is from normal cells. So we also get a picture of what's in the normal cell. So if we see a BRCA alteration at a very high concentration in the tests that we run, it suggests that it might be germline or familial. So there is a potential to look at that from that angle. What we do as a company is we would refer the patient on for the familial testing. And the reason for that is the complications around the familial testing, which is that a patient must consent to it. So we are not requiring patient consent to run a test at Foundation Medicine because we're just looking at what's in the cancer. So if something's seen at a high rate, the patient needs to go back to a company that runs the familial testing and consent to that test.
There is a study going on at Dana-Farber called Inherit that is a familial lung cancer potential marker, and that's an EGFR and T790 marker together. And we have seen it three grandmother, daughter.
3 generations.
Thank you. Yeah.
Don, go ahead.
Just a quick question. I know there's been a lot of progress made on small cell lung cancer, a lot of combos, immunotherapy that are showing progress. And I get people ask all the time, they know that, Foundation multiplex sequencing is productive with non-small cell. Is there enough markers in small cell to make it worthwhile for somebody to go for a Foundation 1 test?
That's a great question, and I'm going to actually expand it across cancers, regardless of whether there's often found alterations or the frequency in a cancer. If a patient is tested, we might find an alteration. So again, casting that net, whether it's small cell lung cancer, whether it's pancreatic cancer, let's see if we can identify an alteration that might be driving that patient's cancer. So it's always worth getting the test to see if we can find something.
Andre, we got about 3 minutes.
Okay, so I just have one quick question. So how does Foundation 1 testing differ from other companies when it comes to comprehensive genomic profiling?
And the size.
So we're looking at a very large number of genes, 315 genes. We're looking at all 4 types of alterations in those genes. The majority of companies are looking at limited numbers of genes. They're often looking at hotspots in other words, just small areas of the gene, and they're not looking at all 4 types of alterations. So I love that you have an NTRK alteration because I can keep referencing it. The NTRK alteration would not be found by 99% of other tests because it's a very unusual alteration that would not be looked for if we're not looking across the rearrangements, et cetera.
All right.
And NTRK doesn't show up in blood either.
Well, it will show up in blood, but the blood test isn't looking for it because it's a very complicated gene and it would take up too much of the real estate. We are going to be adding that to our blood test in 2018.
Well, we do have to wrap up. I want to say thank you, to Sherri for joining us and having a great, please clap. This was great. For joining us. Obviously, some other thank yous, and then I'll get into our housekeeping items because I want to make sure we get our thank yous. Thank you to all of our sponsors, Astellas, Bristol-Myers Squibb, Celgene, Genentech, Lilly, Merck, Novartis, Tesaro, the Yahoo Employee Foundation for supporting this and allowing us to provide this education to the patients and the caregivers. A big thank you, as always, to Peninsula TV for coming out here every month and doing a tremendous job broadcasting this. It will be showing on the public access station. I know that happens on a regular basis, so please look for it in the middle of the night. Obviously, the Office Bar and Grill, who always bring out the food for us for the event, our staff, and then most importantly, a big thank you to all the patients for coming here, both in person, online, and all the great questions for tonight. A couple other final housekeeping items. We do have a special living room that's going to be taking place at Yale. That'll be on November 2nd from 5:30 to 7:30 p.m. Eastern. So if you're in the area, please join us live. If not, you will be able to watch it on YouTube. And then we're moving up.
Can I add to that?
You can add to that.
Okay. There'll be a panel with Roy Herbst.
We got 41 seconds, so you...
we're good. Roy Herbst, Justin Blossberg, their thoracic surgeon, Roy Decker, the rad onc, Sarah Goldberg, med onc, and Emily Duffield, who is a nurse. It's going to be a panel, and I'll be moderating that panel at Yale.
Which will be great. Our living room here in the office is moving due to the holidays. It's going to be on Wednesday, November 8th, so we hope all of you will be able to join us. It's going to be a little bit of a different topic. You know, we asked the question tonight about how our foundation can do a better job maybe educating and some ideas, but what we're going to be doing is asking the patients and the people online about how we can better serve you, and more importantly, bringing up the different people from our team to talk about the work we are doing, how we're measuring our work, the impact we're having, why we're focused on the areas that we're focused on. Things like early detection. Why is that so important? What are we doing? How are we measuring it? And then hear from you ways that we can serve you better. So it'll be kind of what's the foundation of our foundation? Or someone said it's going to be all about us, but really it's all about you because that's what we're here for. And then one final announcement, and this isn't necessarily our event, but the idea of this legislative advocacy came up and really making people aware. On November 2nd in Washington, D.C., there's going to be an event called the Life and Breath Rally. Our goal is to get a lot of patients and caregivers and survivors there because we know 433 people a day pass away from this disease. And yet, even though that many people pass away every day, our elected officials really might not be aware of that, and more importantly, the general public might not be aware of it. So our goal is to get more than 433 survivors there so people can see there's a name and a face associated with this disease and start sharing those stories and making people stand up for lung cancer. So we hope you'll join us. I'll be there. I know a lot of other people will as well, and we look forward to seeing you and having you be a part of that as well. So,
and this was totally patient-driven.
All patient advocate-driven.
Patient Lisa Buonono.
Yep.
And several people that were at the summit in Washington, D.C.
November 2nd. And you can go online, there's a website, you can register. They're going to be asking people to share the stories of those that maybe they know who've passed away, and certainly for our survivors, we hope they'll speak up and share their stories as well and make our voices heard. It's been too long coming. But we need to change that reality, and it starts with all of us doing that. So a big thank you to everybody again today, and I hope to see some of you there.
And I'd like to bring up just a couple of our events that we're having coming up. Of course, our gala, November 11th in San Francisco at the Fairmont. You can see Jennifer here. She's the cake deliverer, if you have any questions about the gala. We also have our Spartanburg, South Carolina 5K this coming weekend on the 21st. This Saturday, you can see Katie out there as well as Anna. and Kim Parham, she'll be out there as well. We also, pending, we have our Healdsburg Marathon, so we're kind of waiting to see if that's still going to be happening on October 29th, but if it does happen, you have to go see Danny run a half marathon, so give her kudos.
We're going to make her run anyway.
Oh, and we're going to crash her house. And then we also have the New York Marathon on November 5th, and of course, our Lily's Light kite flying event in Hollywood, Florida on November 5th.
All right. Well, thank you. All right, everybody. Thank you so much. Glad you could join us, and thank you again.
You were awesome.
Yes. Outstanding. There's cake. There's cake.